will be recorded. 3, 2, 1, thank you. And this will be included in the Nodal pod for folks who want to revisit or for folks who are unable to join today. If you can, replace your name with your organization as normal so folks know who you are, and feel free to use the raise hand feature. At any time, our presenters are more than happy to pause and answer questions that come up. And if you have any other questions about the New Leader Institute, have questions about Nodal pod or anything, please, as always, reach out. Happy to help. I'm privileged to be able to do the introductions today. Again, my name is Ryan Smith. I support Jen and the team here at PCA and Network Relations. I have had the privilege of working closely with these two folks on our screen here, Misty Drake and Dr. Art Jones are consultants with Medical Home Network. NAC has benefited from their expertise over the last couple of months as they have helped us look at our internal resources around value-based care and payment, recommending some opportunities for improvement and helping us as a national organization position ourselves to be able to help and navigate the future on behalf of our constituents here. So it's with pleasure I'm able to introduce to you Misty Drake. She has more than 20 years of experience in community health. She's the Vice President of Client Services and Growth at Medical Home Network and is responsible for building and growing a nationally recognized care transitional model that helps integrated health delivery systems succeed under advanced alternative payment models. Before she joined MHN, Misty was the COO at Piedmont Health Services in North Carolina and has held leadership and management roles at various health entities in Chicago. And her partner, Dr. Art Jones, has more than 27 years experience as a primary care physician and CEO at a Chicago area community health center. The health center has taken a population health approach from its beginning, addressing social determinants of health, as well as the medical needs of the community it serves. The health center is an early adopter of APMs dating back to 1987, and he was actually the architect of the first FQHC APM in early 2000s. He is the founder and continues to serve as the CMO of MHN, Medical Home Network, accountable care organization comprised of 13 FQHCs and 3 health systems serving 167,000 Chicago Medicaid recipients. And with that, I will turn it over to Art and Misty, and we'll sit back and enjoy what they have to share. Thank you.
Thank you, Ryan. It is certainly a pleasure to be amongst colleagues again and to see some familiar faces. I do want to at least start off by also just thanking you guys not only for being here today, but to continue to work with our safety net providers, FQHCs. We recognize that this has been an unusual time for healthcare overall, and so we want to just take the time to really acknowledge and recognize the real heroes that have been doing this work. And so congratulations to you guys, and just thank you for all that you guys have done. You can go to the next slide. I won't spend any additional time, go to the disclosure. I won't expend any additional time kind of talking about ourselves, but here are disclosures so that we can just kind of get them out of the way. Mostly it just tells you again who we are and kind of what we do, just to fully disclose that. Next slide. So today's agenda and what we have planned today. So we will spend a lot of time going over kind of value-based care, what the payments look like, and really kind of understanding the opportunities for FQHCs. We'll talk a lot about kind of the growing competition that you probably see within your local markets, and what we're also seeing nationally, and really how that impacts your ability to reserve the patients that you're seeing, and then also being able to not only reserve those patients, but also kind of moving into these value-based arrangements where you can kind of yield the highest outcomes. We'll also just talk about some limitations with the fee-for-service reimbursement methodology that we're on. And I think many of you guys know that, but also want to be able to talk about kind of outcomes and inefficiencies of new models of care that can further kind of help health centers along. Review alternative payment models and kind of the care models that enables patient access and care outcomes, discuss linkages between payment reform and expand use of primary care workforce. And then finally, kind of review the framework for how CINs can really help health centers to accelerate along this path. And then we'll leave about 15 minutes, 20 minutes or so for Q&A. Dr. Jones, did you want to add anything before we get into it?
No, it's just a pleasure again. As with Misty, I've had the opportunity to meet and to work with some of you, and certainly appreciate this opportunity as well. So thank you.
Okay, next slide. So probably back in April, and again, this is nothing new. Walmart is just one, but there are many. But Walmart announced that they were opening 5 new health locations in Florida with the intent of adding additional footprint throughout multiple different states, including Alaska, Georgia, and Illinois. And their primary model, it might seem very similar. It looks like a FQHC model where we are one-stop shop, right? But they got an advantage because you can also grocery shop too. But what they're recognizing is that this is an opportunity for them. And so you have places like Walmart, and there are some other ones like Oak Street that are really starting to get into the business of delivering care services, and not just providing kind of pharmacy, but just really kind of getting into this comprehensive delivery of care. So they're not, while their name is pretty big, this is a competitor, just one of many competitors that's really vying for the type of patients that we've been seeing. Those that are particularly those that are duals, those that are a little bit more complicated, because those are the key opportunities really that we have in order to be successful. It has a greater potential of yielding shared savings in value-based arrangements. So Walmart is just one, but there are many. And so I think this is something that FQHCs we haven't necessarily been worried about. I think we've been more so had friendly competition with each other, and not necessarily have thought about some of these other disruptors that are coming in, caring for a very similar population. Next slide. But what we also have recognized is that primary care has not lived up to expectations. And so this is why you also have, these individuals that are entering the market because it's, primary care has not been accessible. It has not been comprehensive. And so ideally, what has been the thought is that primary care is accessible, timely, it's first contact, it's coordinated, it's long-term, and it's holistic, right? And I think what we have recognized and what we can probably all agree to here is that there have been obstacles in obtaining primary care. And I think the Institute of Medicine Committee on the Future of Primary Care really just kind of goes into this. And so you certainly see folks that are trying to pivot and rethink of how we deliver care because it's not quite living up to expectations. Next slide. So what the other thing that we have seen is, this need and desire to have high quality. So not only it being accessible, but it being high quality, integrated, and accessible, and that there are these very sustained relationships. And I think many of you guys would agree that we are not quite there yet. But as additional folks come into the market, into the traditional market of FQHCs, they are recognizing that and building their model around kind of that gaping hole. Next slide. So, you know, what we've also seen is just also the clinical outcomes, and, you know, where we've been successful or not with reducing barriers to patient self-management and improving their care over time. So, you know, what we've seen, at least for hypertension, that is 42% of FQHC hypertension patients have a BP over 140 over 90. That's per UDS 2020. Diabetes, we have 36% of our diabetic patients have no hemoglobin A1C, or hemoglobin A1C is greater than 9. And then depression for readmission, we're at 14% over 12 months. So while we've made some strides, there are still some issues with barriers for patients to self-manage their own care and to have better outcomes. Next slide. So pre-pandemic, you know, 142 million primary care visits among 94 million members were examined. And what we have seen, yes, please raise your hand if you have any questions. And Barb, I will lean on you to manage that because I can't quite see everybody. So visits to PCP providers have declined by 24% from 169.5 to 134.3 per 100,000. And again, this is pre-pandemic. PCP preventative visits increase by 40%. From again 15.1 to 21 visits per 100 members a year, but still only 1 in 5 have had a preventative visits. Problem-based visits declined by 30%. The population of adults with no PCP visits in a given year rose to 46% from 38%. And then finally, rates of visits addressing low acuity conditions decreased by 47%, while visits to alternative venues such as urgent care facilities have increased by 46%. So again, this just tells us kind of where we are with primary care and what we need to do in order to pivot and in order to make things more accessible for folks to manage their care. Next slide. But what we have seen is that the pandemic has really changed expectations, not only for patients, but also for the healthcare industry. You guys were in this in the thick of things. You know how swiftly you were able to pivot over to telehealth. I mean, I can tell you when I was in the thick of things, 1 month, all of our visits were in person, and the next month, you know, 60% of them were virtually. By 2 months, over 90% of our visits were virtually. And so we did have to pivot in the pandemic. And I think we're going to continue to see kind of telehealth be at the forefront in terms of ways in which we can engage patients. But what that opportunity shows us is that there is a way to pivot to engage patients in different ways in terms of how they access care. Next slide. So there also have been various industry disruptors that are also just changing the game. And so, you know, these folks have been really successful in recognizing and really responding to consumer needs in terms of making things accessible, like Airbnb. You know, what used to happen 20 years ago, in order to get a hotel room, is that you had to call the hotel. And that was it, right? Or in order to go shopping, you just had to go into the mall, and to watch a movie, you had to go to Blockbuster or watch it on TV. And so there are, you know, all these disruptors that have happened overall with our market. And we're also seeing those disruptors, right, in the healthcare industry that's really shifting kind of how we redefine the way care is delivered. And what that often means is using technology, streamlining our process, and refusing to continue to do things the way that we've always done. Because I think these industry leaders have pointed out that there are ways that we can do it. And I think the pandemic has also shown us, whether good or bad, how we can certainly pivot to do other things. Next slide. And so these are just a couple of again, some of who we see are folks that are entering in our market. We talked about Walgreens. Oak Street is another one that's pretty big in Illinois, but they're also branching out into other states. We certainly have, again, Amazon, and their plans for healthcare clinics across the US. But what are some of the implications is that there is just growing competition with folks that want to care for safety net patients. Less of the uninsured, more of the duly eligible, a lot of the Medicaid folks, and even Medicaid individuals as well. And so that competition is going to continue to grow, and you're going to see health center patient population kind of ciphered off without us thinking about how to respond to the market and how to respond to patients' needs. The other implication is network linkages and clinical assets. The total cost of care and true kind of risk assumption is going to be clinical. So just not care coordination, but also looking at shared savings. So not just P for P, but also looking at how we get a larger piece of the pie. And being able to look at data and have data 360. So not just what's in our EHR, but what's beyond our EHR, and leveraging on infrastructure to create greater interoperability is going to be extremely crucial. And then how do we think about our patients' loyalty and commitment to us, and our commitment to them, as we think about ways in which we start to look at how primary care can live up to their expectations. Next slide. So what we do recognize, and this is a fact, and we just need to address it head on, is that there is a lot of primary care workforce challenges. And we started to see this with the pipeline of primary care physicians in the United States and how that has declined. And the ability of our current primary care providers to meet the demand of our rural areas and some of our urban areas. But over the last few months, and again, you guys know this best, is that the pandemic has also shown us just work shortages, not only just with primary care providers, but with other members of the care team. So whether it's nursing, whether it's front desk staff, and so this is really starting to expand more than just providers. Next slide. And so again, this is just showing the age distribution of primary care physicians. This is based off of 2007. And as you can see, we have a lot of physicians that are aging. And we have to think about how do we create a care model that understands that it takes 8 years to train a physician. How do we kind of build this system that really supports the care model and the care delivery? Next slide. And so one of the things that we have done at Medical Home Network is that we have looked at the collaborative care model for managing chronic care conditions. It is something that is not reimbursable, but what we have done is, in our kind of ACO, we've looked at our shared savings and kind of reinvested that back into our model. Again, the more we are able to kind of address kind of the workforce shortage, it is our hope that that reinvestment will certainly pay off. And so the way that the collaborative care model works is that you certainly have the PCP that's involved, but then you also have other members that are involved in the care team. You have the behavioral health professional and the care coordinator. They're kind of all working in concert with the provider around substance use treatment, vocational rehabilitation services, and connecting patients to resources. You have the primary care physician that is consulting with the psychiatrist, because what we recognize is that we don't have a ton of psychiatrists that are available, but can the PCP consult with the psychiatrist to be able to adjust meds as necessary, as opposed to getting them in for a visit and waiting 6 months for that, or the patient not showing up at all. Next slide. And so what we've learned for launching our collaborative care model in our integrated primary care and behavioral health is that we've recognized the need for both integrating physical health and behavioral health within primary care settings. And I think you guys have been at the forefront of this while also kind of reducing, right, the strain on access to other services such as psychiatry, such as the PCP. So what can the care team handle that the provider doesn't need to handle? How can everybody work to the top of the license where they can see some other members of the care team, whether that's the CHW, whether that's the care coordinator, whether that's the behavioral health specialist, and it doesn't necessarily require a provider visit. And so, as I said, we self-funded this rollout as an evidence-based approach to really enhancing behavioral health care access. And what we have seen as a result of this is that 54% reduction in symptoms in our patients and a 34% reduction in readmission. So again, this is clear, tangible evidence in terms of improving quality and reducing total cost of care. Next slide. So where can health centers get more piece of the pie? We have traditionally lived in a fee-for-service cadence where we get paid our PPS rate. So you have that as one end of the spectrum. And then on the other end of the spectrum, you have capitation. And so there is certainly a bigger piece of the cake that we can get. I like pie better. I think Art likes cake. So I think when I give this slide, I'm going to change that picture up so it can be pie. But at the end of the day, what we want to do is we want to be able to get a bigger piece of the pie. And what that means is that we kind of have to move along the continuum of risk and of going over and beyond kind of fee for service. And what that entails is that could be a care management fee, that could be looking at P4P, but it also could mean looking at shared savings and capitation for non-PCP services. Next slide. And so where we have most of our work is around fee for service. So this is where most of us are. We do have some health centers that have started to move along kind of this continuum, but the future, where we're going, where you hear CMS with them wanting, 100% of their patients to be in a care relationship by 2030. They want more and more safety net providers to be in to move along kind of the land continuum. And I think where we're seeing kind of most of FQHCs are still kind of in the fee for service cadence, but we are starting to see people kind of move along, whether it's P4P, P for reporting. So we are starting to see people to move along. Next slide. And so, questions that FQHCs have been asking themselves as they kind of pursue value-based payment is that, can I continue to do what I'm doing and nobody touches me? And I continue to do the same old. So can I keep kind of being at the status quo? Can I wait for the elevator? So do I wait for somebody to say to me, hey, you got to do this? And quite frankly, what we're seeing in some states is that, they are pushing, including FQHCs, into taking on some risk for their Medicaid population. So do I wait for that push to happen? Or do I call the elevator as opposed to waiting for the elevator to come to me? And then, how we're also thinking about, like, how bad is this going to be for us? How is this going to impact us if we're taking on more risk, if we're moving along the spectrum, and do I really want to make it to the top? Is ultimately the question that we're asking ourselves. And should I hold someone's hand on the way? So should I do this by myself as I'm going to the top? Should I have a rail that's going to help support me? And I think this is where CINs and HCCNs can really come in to play a role. Next slide. And so again, we're starting to see some movements with providers doing pay for reporting. pay for performance and taking some upside risk as well. Next slide. But at the end of the day, there is a gap, right? There is a gap between our model of care and how we our fee-for-service cadence and how we are incentivized or not incentivized in terms of model of care. Because right now we are paid on a fee-for-service cadence, which really doesn't allow us to be innovative in terms of creating models of care that allows us to take on additional risks, that allows us to protect ourselves as well as we're doing that. So I am going to pause right there to see if we have any questions before I turn it over to my colleague, Dr. Jones. And when I call him Dr. Jones, that means that's serious, because typically I just say Art.
Okay. So first I want to just go back to the previous slide for a second. I just want to thank Jennifer Nolte for posing for this picture. We were trying to do the dilemma about what happens when you stay in a fee-for-service system versus trying to manage total cost of care. And she kind of came up with this illustration, and so I said, well, we just need to take it to the next. So I had someone draw her picture as she was posing. Sometimes she'll tell you how long she's able to hold this position, but it wasn't that long. So thanks, Jennifer. In case you're wondering, I'm at a health center in Queens. You think I could like get a better background? I'm just happy to be in this little hole. I mean, this little room. This is a really key little health center in the Queens that is really serving a really vulnerable population. And so I'm doing a site visit here. So I was just happy to get a room that was off to the side. So I'm not in in case anyone was worried, I'm not in a witness protection program in terms of my video. So, but the dilemma that you've seen is that, so I think what Misty has talked about up to this point is that, you know, there's reasons to pursue value-based payment, part of which is that this is where CMMI is going. We've been talking about this, it seems like, for 15 years or longer. But it really is not just about payment. It really is also about patient convenience. The patients are having evolving expectations about how they can access our services. So what about patient convenience? What about the fact that we do have a workforce shortage that has certainly extremely accelerated in the last 2 years, particularly the last 12 months? And so can we better use our existing workforce in terms of our providers, but also can we retain our non-provider workforce by giving them a more fulfilling role beyond some of the roles that they traditionally have? So we still need we still need medical assistants to call people in from the waiting room and do vital signs and receive complaints. But what about if one day out of a week that they are set aside to do that collaborative care model where they are supporting their patients with depression or with hypertension or with diabetes and not making those patients necessarily come in to get that care every time that they want to be monitored? So can that be done virtually? Can they sort of play a community health worker role? Is that more fulfilling that if they know, hey, those patients that I have established a relationship because I actually brought them back into the rooms and done the vital signs, now they know it's me that's actually supporting them and helping them better control their chronic conditions. We've also seen that, you know what, we have rising competition, that in fact, there are corporations and there are private investors that see this as a huge opportunity, and they are no longer being constrained by a fee-for-service system. So up to this point, we've kind of talked about, well, let's stay with fee-for-service and let's also get some pay-for-performance opportunity, which is great. Let's actually reduce total cost of care, which is pretty good down in the literature. In terms of F3Cs actually do a pretty good job through their enabling services, and et cetera, and their late hours of reducing ED visits and hospitalizations. To can we sort of take the next step? What would care delivery look like if we no longer had the constraints of the fee-for-service system? So next slide. So I think most of you are aware, but for any of you who might be relatively new, is that when PPS was created as part of BIPA back in 2001, there was a major overhaul under the Clinton administration in terms of Medicaid. And part of it was they created PPS. Up to that point, those of us that were at health centers, and I was at a health center at the time, is that the more expense we we incurred in 1 year, we could put those in our cost report, and that increased our encounter rate the following year. So finally, after doing that for well over a decade, is that HRSA kind of figured out that probably was the wrong incentive, and so they introduced PPS, which the good news about PPS is that we were being paid more than Medicaid providers, but the bad news about PPS is that it hasn't inflated enough, as many of you know, to keep up with the cost of inflation, particularly salaries. And so they took our 1999 and our 2000 encounter rates, they averaged them, and since that time they've been inflated by NEI, which if you go back and look at it year after year, it has ranged between like 0.8% and 1.5%. And we all know that to be able to attract and retain staff is that that just is not enough to be able to operate the clinic. So we're blessed and we're really grateful, and we certainly don't want to give up that enhanced revenue source. But so we've gone to chasing other revenue sources, including some of these value-based payments. But the question is, one of the things that this legislation did was it said that it gave us some flexibility. It said, yeah, the traditional thing is PPS, which is all paid on fee-for-service, but we allow states and their FQHCs and their primary care associations to actually suggest to us an alternative way of paying for services. But there's a really important caveat, which is at the end of the day, the amount of revenue that an FQHC receives for their direct services under an APM has to equate to at least as much as what they would have gotten under fee-for-service. It can be more than that, but it can never be less. And if it turned out to be less, the state has to make that up in terms of reconciliation payment. When we think back about the, if we could go to the next slide, when we think about one of those questions that Misty asked was, well, how much risk do I take? Actually go one slide up and I'll come back, Misty. When we talk about going up the stairs, and you sort of say, well, how much risk do I take? Is that there are two groups of primary care providers in this country that with Medicaid do not have downside risk with primary care cap. One is rural health clinics, the other is FQHCs. Because we're unlike the private docs, so if they go to capitation, well, maybe they end up with more, maybe they end up with less. That never is the case with FQHCs. So go back to the previous slide. So how does that work? So what we're seeing across the country now, and this is really being led by primary care associations, is that many of them have created their IPAs or in the process of creating the IPAs, but they're also looking at, you know what, maybe I can provide more convenient access to care. Maybe I could use the full care team. Maybe I can be competitive with these other providers by offering models of care that are no longer tied and tethered to just the fact that the only way I get paid is by a billable member of the care team, seeing the patient face to face. So the way they work is that you basically take the historic revenue that an FQHC received for their Medicaid patients for services they provide while they were their Medicaid members, and you divide that by number of member months. And so there's that historical revenue, and then pay that for me instead of on a fee-for-service basis, pay it for me going forward on a per member per month basis. And inflate it. Maybe it's going to still get inflated by MEI, although many of the models we're trying to actually inflate at a rate higher than MEI to keep up with the cost of inflation, but at a minimum, inflate it at least MEI. And then give me the flexibility that as I redesign care, and I decide that, hey, I want to put that collaborative care model in that Misty said, and I want to use a community health worker who is virtually supporting my patient who has depression, and using a person from the community who is trained in the model but very capable. And the fact that many states don't pay for that fee for service, it doesn't really matter. The fact that none of the states are paying for the collaborative care model for depression or for diabetes, but I can use now a member of the care team who's someone from the community that I train, or better yet, one of my MAs, as we mentioned before. That becomes financially feasible. And can we actually improve access, improve compliance? So we start to see that, hey, 35% of our patients of FQHCs have a hemoglobin A1C of more than 9, or didn't get a hemoglobin A1C done at all. That's really terrible. But just to put it in perspective, FQHCs are doing, that's a better number than non-FQHCs for Medicaid. So that is a really sad commentary, I think, for us. I mean, any of us that are primary care providers, I was always really concerned when my patient's hemoglobin A1C was above 7.5, let alone above 9. Like that should be setting off alarms. And when we are same for hypertension, same for the fact when we go look at nationally, what percentage of our patients with depression actually are achieving remission, as documented by a PHQ-9 dropping to less than 5. And we're looking at like 15, but certainly less than 20%. Some states it's single digit. Like we got to do something different. And part of the problem is that the payment methodologies limits us to putting in some of these care models that actually can improve patient outcomes. Next slide. So really, the future for us is certainly our bias and the feeling of many FQHCs and PCAs around the country is to start to relook at fee for service. When this conversation first came up, so as was mentioned, 5 FQHCs did this in Chicago in 2001, and then kind of flew under the radar because we didn't file a state plan amendment. I didn't know what a state plan amendment was. Apparently, the Medicaid agency didn't know what a state plan amendment was in Illinois at the time either, because they didn't file a state plan amendment. No one kind of knew what we were doing, but we were under capitation. But then when it really came to the forefront was when Oregon did this in 2012. And I can tell you there was a fair amount of concern and pushback because there was a lot of misunderstanding that people were giving up PPS. So if there's one thing you come out of this is that when you move to an alternative payment methodology, no one's giving up the revenue. We're not thinking about giving up the revenue. That is actually against CMS will not approve for you to give up the revenue. It's really getting that revenue paid in a different way. So Oregon did it in 2012, Washington State in 2017. The rest of Chicago, that are part of the Medical Home Network, did this prior to the pandemic. So those FQHCs that were not part of those initial few that were still being paid fee for service, we pretty quickly saw in March of 2020 that fee for service was not going to be the safe revenue model that we thought it was, and so we quickly pivoted over to a capitation. So our revenue didn't suffer at all during these next 2 years. And then you're starting to see that Massachusetts is actually, as part of their ACO program, will be moving all of their primary care providers, not just FQHCs, into capitation. California has got our support from the Medicaid agency and the governor's office. They've developed a capitated APM. They tried about 5 years ago. The Medicaid director at that time was not supportive, but there's been a change in administration and they're supportive. And they've kind of moved to where they are in the negotiation. I should change the slide, move over to the right. Colorado, the rest of Illinois, Michigan, Vermont, all have developed their models. They're all in various stages of engagement with the Medicaid agency. And then we are just recently completed work with Georgia, Rhode Island, in terms of creating their APM. Every state's a little different. And so there is a format and template and approach to developing your APMs, but there's got to be flexibility and sensitivity to the local market. And so you're seeing that, again, this is a growing trend across the country. Next slide. But then I would say there's a step beyond that. So there's a step beyond, hey, I'm going to be paid capitation. I'm going to form a clinically integrated network, which again, many PCAs have been the really initiating force along with their FQC leaders to do that. I'm going to do more than just chase shared savings or even take on some downside risk. And that fourth one is a foundational payment. By that, I mean really care management. So next slide. What we know is in Medicaid is that care management is really done by the health plans, right? They're called managed care companies, therefore they figure because they're called managed care companies that they're the best ones to do care management. The challenge for care management done by a health plan is that we know that effective care management really is dependent upon building a trusting face-to-face relationship between the care manager and the primary care provider or behavioral health provider and the patient. And that cannot be done over the telephone. It can't be done from a different state. It's got to be done down at the primary care level. So increasingly, we're gathering evidence that, in fact, effective care management really belongs down at the medical home. Fortunately, North Carolina has seen that, and so when they implemented their managed care back in July of last year, they mandated that qualified medical homes, advanced medical homes, had to be delegated from care management. And those are really the FQCs in North Carolina as well as a few other providers. Let me go back for 1 second because
there's a question, Art. Yes. They're asking you to clarify the 4 states in the capitated APM column are implementing in the same manner.
Okay, just go back to the previous slide then. So there are some variations. Oregon, the other 3 states all do it based on primary care assignment. Oregon does something called attribution because they don't assign people to a particular PCP. So there are some variations. Washington State has decided when we work with them is that an APM without a quality component that had financial implications was not an APM. And so we had to figure out how do we put in a quality component that had financial implications without compromising federal legislation. So it looks a little different there. With Chicago, we pretty quickly did it pre-pandemic. And so we didn't cross all the T's and dot all the I's. We basically did it directly with the payer while the state primary care association is working through the one that will go through state plan amendment. So the FQCs were able to negotiate a PM without having to actually get a state plan amendment, but it was with just one particular payer who we had, again, 168,000 lives. And Massachusetts is doing it under their waiver, so the next waiver. So they're all a little bit different. And even as you look at the other ones, there is some variation in terms of how they implement, but the principles are pretty much all the same. Okay, if we can go forward then to the next. So it really is about talking about, hey, can we get delegated care management? What does that mean? So you can go to the next slide. So as you know, health plans have to be accredited by NCQA. And so they go through a process, which is a pretty extensive process of getting NCQA certification. In theory, if they delegate care management to a FQHC, who is patient-centered medical home, is that those cases all pass. But in reality, if the plans won't do that because they want to see something much more extensive than what you had to prove to as a patient-centered medical home. So basically, there is NCQA has a case management certification project, which is the same process that plans go through for case management. It's 150 metrics. It's a very evidence-based approach in which you start by, hey, here's my assigned patients. I'm going to do a screening health risk assessment. I'm going to then do a risk stratification, identify my highest risk members. I'm going to do a comprehensive risk assessment for them. I'm going to create care plans for them, do care plan updates while I'm doing care coordination for the rest of the population. I'm going to manage transitions to care. So it's a very structured approach, although with some flexibility and variation. And so increasingly, if IPAs are looking to become accredited for care management and be able to get delegation from the plans, that they have to build a model that will make it easy for the health plans to continue to be certified under NCQA. Next slide. And I think we also realized that there is increasing attention under care coordination, care management in terms of social drivers of health. But it's no longer, right now it's been an accomplishment just to start getting people systematically screened. And if you're delegated for care coordination, you're getting some funding to actually do that. But we've got to go to the next step. So the next step is getting them referred to community-based organizations. A third step is making sure they actually showed up. So I made a referral. Did they actually show up? The fourth step, though, is are we actually seeing that some of these barriers are getting resolved? So it's kind of like where we were with diabetes. When hemoglobin A1Cs first came out, it was great that we could just make sure we're kind of screening which of our patients had diabetes. Then it went to getting a hemoglobin A1C done. If I did a hemoglobin A1C, I got a star. And then it got to, well, that's not enough. It's not just enough to do a hemoglobin A1C. You got to have their diabetes controlled. Well, I think that's where we're going to be with social drivers of health, is that we've got to move beyond screening, about referral, about sort of saying, well, are we effectively in close collaboration with community-based organizations, seeing that some of these barriers are getting resolved? So you do that by actually repeat screening. So this is the experience in MHN. You can sort of see the things that we screen for. That again, we kind of said, what makes it difficult for our patients to comply with their treatment plan, and which of these can we actually deal with and try and address either by ourselves or in collaboration with CBOs? And we got to go back and see, does it work? And what we think is the most impactful factor is that second one. It says patients rank their overall health. So as you know, there's plenty of evidence in the literature that this is one of the most important things. And you think about it, it should be really important. You just ask a simple question: how do you rate your health? And they give you 4 options. You can either say poor, fair, good, or excellent. And if we're really doing a good job of managing our patients, we want to see that the percentage of patients that are responding fair or poor is going down, and those that are viewing their health as being good or excellent is going up. And part of that is using my stethoscope and my prescription pad, but a lot of that is addressing social drivers of health. Next slide. So if we're going to do care management, then we need to be able to say, well, how do we identify those patients that should be complex care management? So typically, like at MHN, we high-risk care manage 3.2% of our population, and we care coordinate the rest. But who is that 3.2%? And so what is available in the literature or out in the market is that there are tools like Milliman has one called Mara, and Hopkins has their own tool, and others have, 3M has a tool that basically just uses patient demographics. So how did you become eligible for Medicaid? How old are you? What your sex is? And use claims as far as, hey, what diagnosis do I have and what's been your utilization of healthcare services to do risk stratification. And that certainly is good, but it certainly is also pretty lacking. Because if we said that it's really important to determine social drivers of health, is where does that get fit in? So one of the things we did was we actually screened and said, well, if somebody has several of those social drivers of health, were they going to be more expensive going forward, even if they historically have not been expensive? And so we published that data in 2017 that really showed that they were predictive of future hospital utilization, both ED and inpatient, and future cost of care. So why aren't we incorporating that information into our risk stratification? So what makes someone high risk could not just be that they have heart failure and diabetes, but they have heart failure and diabetes and don't have transportation to their appointments, or don't have the diet that they need to comply, or can't afford the copay for their medication. So it's really about, we have to incorporate these. Well, there's so many factors, and we put on top of that, well, what about, should we be risk stratifying based on the fact that the patient is not taking their medication? Do we need to wait until a claim comes through to risk stratify? Because we know that once somebody's hospitalized, by the time that they're out of the hospital, the claim gets filed, it gets acuity, it gets claimed, it comes back into the risk stratification. It's often 2 to 3 months. That's too late. So we want to dynamically risk stratify based on getting an alert that the patient just registered off of the HIE, that patient just registered in the hospital. So it's really taking in these multiple sources of data and dynamically risk stratifying. So at any one time, you are impacting and high risk care managing that group of patients at highest risk who you can impact. So don't give me a list of patients that are on dialysis because they're going to be expensive. Don't give me a list of patients that are in active chemo or radiation, unless there's something else going on, like their condition is so poorly controlled that they're going to the ED or hospital. And so that really takes artificial intelligence. None of us can be so smart as to say, well, for each one of these factors, the myriad of factors, that I'm going to assign a weight to them, I'm going to add up the weights, and that's where risk stratification is. And it means that you have to be able to tie whatever your algorithm is to what is it you're trying to predict. If you're trying to predict future ED utilization, if you're trying to predict the patients that were hospitalized who's likely to be readmitted to the hospital, that's a different algorithm. So it's using artificial intelligence to actually guide your care management task. Next slide. And then beyond that is, don't give me a black box. So if I'm a care manager and I get a list of who my highest risk 2% of patients are, and I just get a number, that doesn't really help me. It helps me some, but go to the next step, which is, what is it that made that patient high risk? Was it the fact that they stopped taking their psychotropic medicine? Was it the fact that they just hit the emergency room? Was it that they have a new diagnosis? Was it that they lost their housing? So again, what you really want out of your risk stratification algorithm is for it to be dynamic, and ours is recalculated in a real-time basis, but also to be able to tell the care manager, and this is what really is making them high risk. So when they start to do the care plan, they obviously want to listen to the patient. They want to let them identify what goals they want to be working on, but they're also kind of informed that, you know what, they may want to work on this particular goal, but at some point I got to get them to take their insulin. Next slide. So, and then I think finally is that the future for us is identifying that there are some patients, despite they're in high-risk care management, they're still failing. Like their needs are not getting met. They're still in the ED. They're still not taking the medication. They're still hospitalized frequently. And then it really comes down to us to identifying that small set of patients that need a multidisciplinary review. That I need to get together the care manager with the PCP, with the behavioral provider, sometimes the pharmacist, the social worker. And you got to be really highly selective because your PCP's got to see patients, right? But at the same time, if I have somebody who is so complex that the care manager really has not been able to help meet their needs, it's going to take a multidisciplinary approach. And so I think the future for us is under a total cost of care contract, it makes sense. Under a fee-for-service system, quite frankly, I'm not going to get money from reducing that utilization cost, and I've got to have those PCPs seeing patients, because I can do 3 PPS visits in an hour. On the other hand, if I'm in a total cost of care contract, one of the most valuable things I can do is get the PCP's insight along with the behavioral and pharmacists and others. Even though that's expensive use of their time, in the long run, it's the right thing to do, but it's also financially feasible. So I'm going to give you, just go to the next slide, a couple of examples. So I think across, as I look at who's attending, the states are really in different places. So I'm going to give you a couple of examples. There are states that right now the FQHCs are just starting to trying to figure out how do we really get engaged with value-based payments. So what the situation is with Indiana is the state has a pretty meager pay for performance program. It's like $2 per member per month opportunity. There's like a myriad of metrics, and it's like, okay. And there's been a couple of FQHCs that have gotten involved with some value-based payments, but in general, most of the FQHCs have not done much in terms of value-based payment. So in that particular case, the FQHCs got together with the association, and they have their own. The PCA also runs the ACCN. They're using those RR drives, like many of you are, and it said, okay, what are we gonna do going forward? Next slide. So really, a first step for them was to do a strategic planning session. If we could go to the next slide. So they really asked themselves 2 questions: Is it the right time and the right thing for us to form an integrated delivery system? And so they're asking their FQHCs in this planning session, is this something you want? What's the feasibility of doing this in Indiana? Because in Indiana, part of the reason they've had is there hasn't been a lot of opportunity. The state has not been pushing value-based payment. They're not pressuring the MCOs to do it. So they have to say, well, maybe if we're going to do this, we're going to have to be the initiators, because the state's not necessarily going to initiate it. So one question that they're currently asking themselves is, should we create an FQHC-led clinically integrated network? And they see their colleagues, some of who are on this call, that have been successful in doing that, and they're asking that question. And the second they're asking is, should we change the way we're getting paid for our direct services by going to capitation? And the third question is, should we do both? So I think the options are they do neither, they do one or the other, or they do both. And that's really what they're struggling with right now. But because they've gotten, the PCA has taken the initiative to bring leaders from across the state around the table to struggle with this and to kind of look at the pros and cons and the feasibilities of doing this is something that I think has been really good experience for the PCA staff and the ACCN staff, as well as the FQHCs in the state. So that's kind of one example. Another example I'm going to show is North Carolina. And so if we go to the next slide. So North Carolina is a predominantly rural state. I think you know that. It's Republican-controlled legislation and governor, but they're moving more towards the purple type state. They have 39 FQHCs, but they have not expanded Medicaid. There's been some progress recently. I can't remember. I think it's the Senate that's passed, and the House has been reluctant, and they're kind of slowly urging their way along that line. But as a result, you can see that they say 40% uninsured. When I look at these states that their FQCs are operating in a state that hasn't expanded Medicaid, you gotta take your hat off to them. I mean, it's really hard when you have 20% Medicaid and 40% uninsured. But they are committed to their state and to their population to make it work. And so what happened in North Carolina is there was no Medicaid managed care until July of 21. So what did they do? Is they formed a clinically integrated network, and they went after Medicare, and they got some experience with it. So the next slide is they operated under the Medicare Shared Savings Program. for several years. They were always successful in generating savings. Misty was actually COO of one of the largest health center in North Carolina. And what she'll tell you is that they were successful in generating savings, but never could get enough that they actually got paid anything. Because there's a bar that you have to generate a certain amount of savings, or the CMS wouldn't do it. So after a few years, they kind of got discouraged, but that was valuable experience for them. And as they saw that the state was starting to move towards Medicaid managed care, is that they took an active role in terms of advocating. Ben Dollar, who was the PCA director at the time, was very active in terms of advocating for this. They convinced the state that really the focus should be on primary care and on medical homes. So they're able to negotiate for them, as well as for other primary care providers in the state, a per member per month fee for meeting state criteria for being an advanced medical home, which sort of look like patient-centered medical home. And then they also, as the state finally moved to Medicaid managed care, because they were so active politically, is they were able to help convince and advocate for the fact that care management belonged at the medical home level, and the state bought into that. So next slide. So they started last July, so they're now coming up on just another week or so. They'll have finished their first year, so the results are still out there. But they developed an NCQA compliant, because what the state expected was that, although it takes time to get NCQA certification as case management, is that they had to be on that path. And so they're on a path. They developed the policies and procedures and workflows that are very compliant with that. They passed readiness review by the state. They passed readiness review by the MCOs, and they're operating under a shared savings arrangement for in Medicaid, as well as some paper for loans, and they're getting paid a care management fee. So I think these are just a couple of examples, and the colleagues that are on the call here and your colleagues across the country, there's a wide variety of experience. I see Joe Purley is on the call. I think hopefully most of you are aware, but if not, is that Joe and others have helped organize a learning collaborative. I think, Joe, you can correct me, I think it's over 30 different states that are participating, and really, again, has the full range of PCAs that are just kind of thinking about, do we do something to those that have been doing Medicaid managed care under a shared savings or shared risk arrangement for several years now. So if you're interested in this and not part of that, I would encourage you to contact Joe. They're working very closely in collaboration with NAC. Slide. So finally, I would just kind of say in the last couple of closing findings, if you're going to form a clinically integrated network, a mistake that often gets made is that people focus on the governance. It's all about who has control, who has ownership, and that's certainly important. So I don't want to minimize that. But if you form a clinically integrated network and that has been your sole or your predominant focus, you're not going to be successful. It's really about sort of saying, okay, if we come together, you've got to think about what are we going to do differently? How are we going to serve our patients better? How are we going to improve patient outcomes? And that's doing things like, hey, how are we going to screen for social drivers of health? What role are we going to play? Like maybe the plans aren't going to give me delegated care management, but maybe I can play a role in care coordination. What am I going to do to come up with new models of care and take advantage of the fact that there's not an adequate workforce? And maybe what are my new models of care? How do I connect and share? I know several of you are ACCNs. How do I collect information across my network? How do we analyze that data? How do I get claims data from the payers? How do I get ADT feeds and alerts from off the HIE? How do I put that information together? And then be able to have a committee structure that looks at that data and says, here's my opportunities, here's what we're going to do different to better serve our patients. How do we engage our patients better into self-management? How do we come up with models of care with self-monitoring, with support from really culturally sensitive members from the community, even though they don't have a clinically licensed? Again, making sure that they're trained, so we're not asking to do things inappropriately, but making sure that we're taking advantage of the full workforce. Because quite frankly, there are things that a person with the community with a high school degree could do that we can't do with my MD degree. And then finally, how do we negotiate value-based payments, and how do we distribute incentive dollars in a way that really reinforces the outcomes we're looking for? So these are the 7 key blocks that building blocks that we have been focused on in MHN now for 8 years. Is with our integrated delivery system, and we keep coming back to them iteratively. What do? We have groups that are working on each one of these to improve our outcomes. Next slide. And that requires really having a pretty, this is a committee structure we have at MHN, but you'll see it very similar in FQHC-led IPAs, where they have their clinical committee, they have their network committee, they have a finance committee. Sometimes the mistake gets made is that they relegate the clinical committee to just improving quality. And certainly there needs to be a quality subcommittee, but you've got to be looking at, okay, what are the other work groups that we need to have? So there are certain utilization patterns. What are we going to do about inappropriate ED utilization? What are we going to do about preventing hospitalizations or transitions to care that are reducing rehospitalizations? What are we going to do about special populations? And having these work groups that are continue to look at their data, making recommendations back to a clinical committee who says, yeah, this is as an integrated delivery system, this is how we're going to manage this particular situation. And then how does that get implemented down at the FQHC level? Next slide. So I think that the framework really is about us coming together. Obviously, the patient is at the center, but it really means that we're going to have to look beyond our traditional model. Our traditional model, back when we first started a health center, the one I was at in Chicago in 1984, was all about providing really good quality care. And it still is about providing really good quality care, but it was focused on patients that walk through the front door. And now we've realized in population health is that we have to also do really good quality care to people who don't walk through our front door. How do we engage those members? One of the biggest frustrations I hear from FQHCs is that, hey, you know, the MCO assigned me some patients and they're not, some members on my panel, they're not my patients. Well, guess what? As we saw Misty's slide there, is that there's a lot of patients, Medicaid or otherwise, who are not going to see a PCP. Okay, so we have responsibility for them. And the trick and the challenge for us is how do we get them to become active patients for us? And it's easier said than done, particularly for a population that often doesn't have an accurate phone number, or the phone number keeps changing or the address keeps changing. But that's part of our challenge that we have to take on as federally qualified health centers. So it's really about us doing that, taking advantage of screening for and addressing social drivers of health, identifying with risk stratification who are those patients that need that special attention for care management, getting delegated for care management, and really working with the community. That in fact our role is still limited as medical providers, that we have to work again with other providers, community-based organizations, and behavioral providers, et cetera, to really improve the health of our patients. Next slide. So when you look at the role of the CIN, in terms of if you do decide as a PCA that you're going to form a clinical integrated network, there's several roles. I do want to, so we've kind of listed them there. We're not going to spend time going through this, and you guys will get the deck. But certain things that you will do, certain things that you will leave to the health plan. So don't assume that everything under that CIN are necessarily things that you're going to want delegated for. You may decide, for example, that some of the back office support is done by someone else, et cetera. But there's certain roles when you create a clinic integrated network, as you go through all of these tasks and kind of say, which ones do I want to be accountable for? Which one do I want to leave with the health plan? Which ones should be done by the health centers? And which ones are appropriate for my health center control network, particularly in terms of supporting that and providing that infrastructure that informs your model of care. Next slide. So just as a reminder, it's all about improving patient outcomes. It really starts by saying, what would we do different? Before you go off and form a clinically integrated network, before you go and pursue an alternative payment methodology, I think you first have to sort of say, what do we want to do differently? And then you modify your payment approach to support that model of care. So if you always start with what are the opportunities I see to improve patient outcomes, then I'm really limited by the fact that all I'm being paid for is fee for service under a PPA system. And whether I move to capitation, whether I move into a clinical integrated network that gets some financial dollars to do that thing because they're delegated for care management or because I got a shared savings arrangement, it all starts by saying, what do I want to do differently? Which of those things can I not do under the current fee for service system or not sustainable? And then that's where you then build your payment strategy around that. I think we're going to stop. I know there's one more slide, but or maybe I'll just go over the last slide because I want to make sure we leave time for questions. So this is my well, second to last slide, sorry, is is what does access look like for us? So what I think will happen in the future is that our patients will access our system differently. There are certain visits that still need to be seen in person, face to face by a billable provider. There are still some of our patients that's the only way they want to access service, just like access services. Just like there's some people, the only way they want to go see a movie is to go to the theater, buy popcorn and pop, and have surround sound. But there's people that want to be able to stream the movie from the convenience of their home and time is convenient for them. Well, that's where healthcare is going to be going. Healthcare is lagging behind other service industries and how they provide access to their services. But there will always be some things that require in person. I think increasingly we're going to see the chronic conditions, whether it's diabetes, hypertension, depression, but also other chronic conditions, are increasingly going to be managed with really providing self-monitoring and support from the practice, which doesn't mean sitting in my waiting room at a time that's convenient for me, but not necessarily for the patient. And really using the extended workforce to support those patients in managing their chronic conditions. So I think you're going to see more and more of that in the future. When it comes to when patients get acutely sick and they call in, we're going to move off of our current system. So what happens now is that almost all of us have open access. And what that means is that there are certain slots that only get filled that morning, but no one's triaging to decide do they really need to be seen, because we're under a fee-for-service system. And I've left some slots open, so I better fill those slots and get paid my rates. Otherwise, I have a financial problem. But if you move to a capitated system, it will all be about, hey, when someone calls in for a visit, the first step is to send them to a nurse, who will then sometimes decide, you know what, I can deal with this condition without them having to come in. So they deal with it. Or sometimes they'll say, you know, this is a visit, this is a condition I think can be dealt with by telehealth, and I'm going to do a warm handoff to a telehealth provider who's going to help this patient. And there's going to be some patients that you got to put a stethoscope to their chest and you got to feel their belly. And so they're going to come in for those visits because they need an in-person visit. But guess what? What too often happens now is that it's on a first come, first served basis, so the slots get filled up with patients whether they need to be seen in person or not. Not to their advantage, but because that's the financial model. And then it gets to be 2:30 in the afternoon, and all the slots are gone. And then we wonder why people go into urgent care centers and ERs, because they can't get in. And some of them actually need to be seen. So I think we're going to rationalize how we provide access to our service, to our services. Again, giving people choice, but also making sure we're really giving them choice that will be much more convenient. This is literally my last slide. Is that you know what, state and local and federal governments are moving providers into value-based payment arrangements. And like I said, if you're in Massachusetts, you're moving into capitation. You already have moved to, as an F2C in Massachusetts, as an ACO structure. You're in New York. The state has made it really clear that they want to move providers into risk. As much as we resist downside risk, and for some really good reasons, is that some states are being really pretty pushy and pretty aggressive. And we can only expect that that's going to increase. CMMI came out last fall as sort of saying, we've been focusing on Medicare, we're going to focus on Medicaid into value-based payment. I don't think necessarily capitation is the solution for everybody, but I would encourage you not to have a knee-jerk reaction and sort of say, well, we're not going to give up our fee-for-service PPS. But I think every PCA with their F2Cs need to take an honest look to say, is this appropriate for me? Is it appropriate for me at this particular time or not? And then it's really is your role as a PCA and as ACCNs are really there to foster and develop new models of care and provide leadership to help their F2Cs to be able to envision the future and what do they need to do to position themselves. I think we've all seen in industries, and I don't mean this in a threatening way, but we've all seen industries where the industry started to move and there were certain vendors who had really control of their markets that didn't transform. And when they got left behind, and next thing you know, somebody else took the market. We don't want to be saying that for F2Cs 10 years from now. I would encourage you to take a really serious look at what your value-based payment strategy is in your particular state. Every state's different. You know, what's the local environment? What's the appetite of your F2Cs? But a lot of this is about educating them and opening up to new opportunities. I want to stop at that point and open it up for some questions and discussion.
Wow. Thanks, Art. Thanks, Misty. There is Elena from Rhode Island does have a question.
Hi, thanks so much for that presentation. It was very informative. I've got two questions actually, and so maybe they're very different. The first is, could you give a little bit more flavor to why the competitors that Misty identified at the beginning of her presentation, the Walmart, Walgreens, what is it about Medicaid that's so attractive? I kind of get the duals piece, but I'm curious about the Medicaid, especially with the estimates that the unwinding is going to decrease those numbers considerably. And then the second question, oh, okay, go ahead. Should I
Why don't we do
stop?
that and then we'll come right back. Misty, go ahead. You're on mute. Misty, you might be on mute.
Yep, I am. I think where the greatest interest is going to be is probably with the duals. Again, those are really kind of like the high cost Medicaid individuals, and where there's opportunity to further coordinate their care and further to reduce total care costs. However, I think, again, I think what they are recognizing is that there is a gap in accessing to care for folks. And we've seen that with urgent care facilities kind of popping up over the last 20 years, and kind of being in a space where they were meeting a need of when folks couldn't get into their primary care physician's office. And what better way to see your doctor while you can also shop for your food and pick up your prescription as well. So I think they're probably approaching it from very two angles, where they're becoming one-stop shop like we've always done, right? Where we've talked about, let's offer dental, let's offer medical, pharmacy, all in one shop. Let's bring in food while we're at it, right? And when you look at the demographics of folks that probably care for them, they are probably a good portion of folks that are within the safety net. All right, I don't know if you want to add anything else.
Yeah, I would agree with that. I kind of break it into two groups in terms of competitors. One is,
all right, something's wrong with your volume if you're talking.
Something's wrong with what? Do you hear me okay now? Yeah, okay. I really break the competitors into two groups. There's the group that are the Oak Streets, the Shenbeds, the city blocks that are clearly focused on the high cost, complex patient group, because that's where the savings. There's not a lot of savings, quite frankly, in healthy 8-year-olds, okay? And so they're trying to cream off, and I say cream off, I don't want to be too negative, because actually they're developing models of care that often we as FQCs haven't, in terms of providing convenience and going for these complex patients. But that's who they're going to compete with the FQCs for. And then there are the Walmarts, the CVS, the Walgreens that are competing for the broader population. And what they're trying to do is be one-stop shop. So remember, when the patient comes in there for primary care, they're much more likely to also buy other things. It's all about driving foot traffic. And they see the amount of dollars. And yes, you're right. There's going to be, when the emergency period is over, 15, 20% of Medicaid patients likely are going to lose eligibility. But there's still a really large group of patients, and they're trying to do, because they can make money off of their other product lines while someone has foot traffic coming into BC and their PCP. So I think they have a little bit different business model than the competitors that are really more the Shenbeds, Oak Streets, city blocks. You want to ask your second question? Does that answer your first question, Ellen?
Yeah, no, it did, and that's really helpful. And we've been talking to the health centers here in Rhode Island. We've got Oak Street Health. They're not doing as well here in Rhode Island as I think they had hoped. They've already had to close down one site, but it's clear that the risk is there. I guess, is there hard data that shows in any jurisdiction where those models, whether it's the Oak Streets or the Minute Clinics, Walgreens, Walmart, where there has been a significant impact on the health center patient population, or is it still early days for that?
Yeah. Well, first of all, they keep their information soft. So you're not going to see a lot of, other than their reports to their stockholders, they may give you something like that. I mean, Fred Rockman's on the call from Chicago. I mean, I'm hearing anecdotally from our FQCs in Chicago that they're taking their Medicare patients. I don't know, Fred, if you want to add anything or not.
And I think it is anecdotal, but it's I think it's also real, right? They see their patients calling up asking to transfer their medical records over to O Street. So while there hasn't been kind of like this report to kind of analyze the true numbers, I think what they're feeling is quite real in terms of their patients switching over here.
Yeah, sorry, I was trying to get off double mute. I think it's anecdotal. Unfortunately, I don't think there's good data.
Yeah, I agree. Okay. Ellen, do you have another question?
I do, unless I don't want to monopolize the time, but my second question has to do with risk, downside risk. And if you could just spend a couple minutes talking, I think I understand the whole issue about the PPS can't be at risk. So let's assume that, but risk in general and why it's important. Why is downside risk important? Is it that much of an incentive, or can you get success without downside risk?
Absolutely. So, and it's not just PPS can't be a downside risk, but also it's pretty clear that HRSA will not be happy with you if you put your 330 grants into covering losses. So that is really clear. And so what you're seeing is that one of the advantages of forming a clinically integrated network is you form a limited liability corporation in which you can put some of your non-grant, spend some of your non-grant related, and Jennifer and Ryan, keep me honest here, you can put some of your non-grant related revenue into as an investment in that LLC. And then what's really at risk is what your investment is. So you're not putting your health center at downside risk. And so that's how you can take risk without violating expectations. On the other hand, we only have so much revenue, right? And so sometimes when you feel like you saw some pushback with ACO REACH that came out this year, that it's really a substantial amount of reserves that has to cover that. And so the question is, do we want to tie up our resources into those reserves? So that's kind of in terms of the benefits of doing it, is that I can tell you, because we started before I knew what I was doing, okay, back in '87, started taking downside risk, and sometimes naivety is the best thing, right? And so we started taking a lot of downside risk. I can tell you we paid a lot of attention to it. And sometimes this idea is, hey, maybe you'll earn a pay for performance period, a pay for performance payment 18 months from now. Maybe you'll get some shared savings, maybe you won't. It's pretty hard to focus on doing things where you're not sure that when there's that long a horizon. When you have the potential that you're having to put something at risk, I mean, there's plenty of studies that are out there in terms of the psychology behind that, is that people pay more attention to it. And I think the payers have really recognized that as well, is that sometimes people get into shared savings kind of say, well, maybe I'll do it, maybe not. It's kind of a laissez-faire, but I'll keep doing what I've always done. And so I think that's really why you're seeing that. And then in terms of primary care, it really is about, and I think, I don't know, because I'm not in Massachusetts. I don't know if there's anyone on the call from Massachusetts, but I think it has to do, personally, I think it has to do with the flexibility. They were recognizing our population is aging, our workforce pipeline is inadequate, primary care workforce. We're going to have to do something different. We cannot use the typical model we continue to do because there's not enough to go around. And when there's not enough to go around, who is it that gets shafted? It's the poor, right? And so we as FQCs have to be thinking down the line about this: is how are we going to continue to meet our mission with an inadequate primary care workforce?
And if I can just add one other additional thing to Art, NAC puts together this chart book that I love. I think I'm calling it the right thing, where it talks about it. There's a bunch of different data points that is there, but there's one that's really interesting that we quite frankly use all the time. And it's the one where it's looking at the aging population of health center patients. And so patients over the age of 65 is the fastest growing population of health center patients. 2 years ago when they did this report, it was at, I want to say 35% or somewhere around there. The most recent report has it, the growth being at 101%. And that's not surprising, right? As health centers are aging, a lot of us are approaching where we're celebrating our 40th and 50th year. Our patients are aging with us. And so that's not surprising. The way we care for moms and babies is very different than the way we care for seniors. And so we have to think about what that model of care and that support looks like for that aging population.
Can we get that report in our resource list, Jennifer?
The report, I'm sorry, which report?
I think she's referring to the chart book report. I could be calling it the wrong thing. I can put it in the link.
Okay, great, thank you. And then we'll make sure that the slides are in NautilePod, as well as we can make sure that the link is in NautilePod too.
Any other questions? I don't want to take out, you might have other agenda items.
You're fine. We've got a few more minutes.
Okay.
So you're fine. Lathrun, I know, has a question.
Question of a request to, first, thank you for agreeing to sell the slides. Missy, I was steady sending you a private one and saying, I know it says proprietary confidential, but this is a great slide. And we're having in South Carolina, our health centers are meeting in July to talk about this exact subject, because under continuum of dealing with value-based care, we have them from one extreme to the other. So I think the slides you provided can really give a visual for some of our centers who aren't as up to speed on. So thank you for agreeing to share the slides. The question I really had when I first had my hand up, when Alina asked about the impact of these retail groups on FQHCs in terms of patients. We may not know what Walmart is doing or these other groups in terms of their patients because they're keeping their data close to the chest. But I think that's something that NAC and us as PCAs need to be looking at the other end of, are our centers losing patients? If there is one in the area, we may not know their data, but are we losing patients? And what is the payer mix of the patients we're losing? Okay. And from my public health days, we did something similar with looking at an FQHC in this area and one not in the other area. We looked at our prenatal admissions and first admissions and had to account. The only difference was the presence of an FQHC. So I'm kind of doing the reverse. The presence of one of these retail groups like Walmart in the area of FQHC, and you start losing patients, that can be some indicator to start doing more of a deep dive. And my concern is not just losing patients, but which patients are they losing? So that's something I think we as PCAs may need to monitor, because when Alina said that, it kind of clicked with me of, we did the same thing kind of around COVID, but in some areas like South Carolina, our Walmarts approached us because they were using, I know mid-level is not the politically correct term, but I'm old school, so I still use it. And they needed preceptors for them because they couldn't act independently. And so they wanted our doctors to precept them. We're like, we're not going to do that. But they haven't taken off in South Carolina the way they have in other parts of the country. But I think that is something that we need to be looking at. Our patients, our centers losing patients because of that.
A good point. Yeah, and realize they're just getting started. Walmart has 20 clinics. You saw the public announcement that just came out 2 months ago. This is their strategy. Walgreens announced that they're partnering with VillageMD. They're going to start over 500 clinics, continuity of care clinics across the country, and the majority of them are going to be in medically underserved areas. So that's their focus. So we're just starting to see the tip of the iceberg in terms of their strategies. Other questions, comments?
There was 2 comments in the chat. Michael Curry from Mass League. For art, many factors that contributed to the shift, but what you mentioned is among them. Massachusetts. So I don't know, Michael, if you want to expand on that comment or not. Okay, and then Libby Thurman from Tennessee, PCA. Tennessee PCA's member health centers are experiencing market competition from many directions, including payer-based primary care clinics. We would like to do an analysis like Lathrun is discussing regarding which patients are going to these clinics. So a lot of different things happening in the market as far as what's becoming available for patients. So any additional questions or comments for Art or Misty? Or Art or Misty, do you have anything, any final words for our participants?
No,
So
I don't, Joe, do you want to talk about the collaborative at all? I mean, do you want to mention that? I do think it's an important resource. I don't know if Joe Purley's still on or not, but
He is.
Yep, I'm here. And I'm happy to, Art. I think most folks probably know about it, but we do have a PCA value-based care collaborative, which 32 PCAs are fully in, meaning they each contributed a certain amount of money to make this happen. So, but we are rolling out trainings and webinars, and that will be ongoing through most of next year. So. And Art and Misty, we look forward to you all participating with us in that effort as well. It's mostly focused on the infrastructure pieces, not necessarily the payment piece like APMs, capitated payments, so on and so forth. Now we know that payment and value-based care delivery is linked, no doubt, but we're focusing more on infrastructure, meaning should your PCA develop a CIN? Should they manage a CIN? What services can a PCA provide in support of a CIN? How can PCAs model their HCCNs to support health centers moving towards value-based care? So just wanted to be clear that the focus is more on the infrastructure, not necessarily the payment piece.
okay. Yeah, and then again, Jennifer, Ryan, and we've been working with them and with Ben, who really are looking at NAC strategy, and we know that Elevate is an important tool that is, people are not taking advantage of. We want to make sure they're taking advantage of that, but they're also kind of looking at what's the next iterations for their strategy and kind of bringing it together. They have a lot of resources that are out there, but we're kind of bringing them in so it's easier to access. So I think you'll be seeing NAC provide increasing support again for you, as because this is only going to grow. I mean, I think anyone who doesn't see that just the fee-for-service system, I mean, this is not a passing fad, and we are going to have to continue to evolve and meet the new demands.
Perfect. Thank you so much, Art and Misty. We are indebted to your expertise as always. We will be sharing these slides. I'm sure folks will reach out to you if they have questions. We're always happy to push their questions to you as well. So thank you so much.
Thank you, guys.
All right, thanks for the opportunity.
Have
Bye-bye.
a good day.
All right, and with that, I will transition over to Andy.
Great, thank you, Ryan. And thank you, Dr. Jones and Misty, for a great presentation as well. I think Dr. Jones kind of pushed us in the right direction for the next section, which is our meet and greet. And we have two NAC divisions on the call this afternoon for meet and greet. The first is our clinical affairs division. And Dr. Jones mentioned Elevate specifically. and that falls under our clinical affairs division. So I'm happy to introduce and welcome NAC's Chief Medical Officer, Dr. Ron Yee, and Cheryl Modica, the director of our Clinical Quality Center within our Clinical Affairs Division, to share some of the work that they're doing, specifically around Elevate as well. And then we'll also be joined by Ben Money and Sarah Halpin from our Public Health Priorities Division about 15-20 minutes from now as well to share some more information from that section as well. So with that said, I'll hand over to Dr. Yee and Cheryl.
Yeah, thanks so much. Let's see, let me just get the right sharing screen on here. Good. Got this screen there with the Clinical Affairs Division there, Andy?
Yes, thank you.
Okay. Hey, thanks everybody. Welcome. Thanks for being here. Looking forward to spending a little time with you. And I'm Ron Yee. I'm a family physician. I get to serve as the Chief Medical Officer with NAC. I served in a health center in Central California, working with farm workers and their families for 20 years. And then I came to NAC about 9 years ago. So I just have a couple slides just to illustrate what we do in the Clinical Affairs Division, and we'll be open for questions later on, but I wanted to give you an overview, and then I'll have Cheryl Modica talk a little bit about our Quality Center and the Elevate platform. Many of you are involved in that. So the Clinical Affairs Division, really our goal is to really position health centers, PCAs, and networks as really the premier way to do healthcare in primary care for the nation. Not only for the safety net, but I think we have the best model overall. And this really comes into play after the discussion with Art and Misty on value-based care. And really, we're set up to do the most cost-efficient, best clinical outcomes with very hard to reach and difficult populations. So our goal is to really do that work on the front lines through our project work, but then to feed that information, data, clinical outcomes, and stories to our policy folks so they can go to the Hill. So you all can use this on a state basis and talk to your state legislatures and funders. So we do this through 4 ways to position the health centers, networks, and PCAs is really the quality infrastructure. We've put a lot of time and effort into building an informatics team of 9 people over the last 2 years. Dr. Julia Skapig is in charge of that. That 9-person team can actually write their own software now. So our goal is to really work on those workflows, information technology, and data aggregation and cleansing and validation so that we have good data to work with. Number 2, we also found that we need to have uniform measures so that we have the right data dictionaries, data sets, so that we can tell that story. And along with that, Cheryl will talk about this, is really finding some good practice guidelines, some of the best and promising practices around the nation that are done in health centers. Along with that, while we're doing this work, is our whole goal is to integrate primary care with behavioral health, public health, and oral health. So we have a whole person medicine approach. And finally, what is the workforce we need to accomplish all this? And we work closely with the Bureau of Health Workforce, the Bureau of Primary Health Care, to determine what that is. And is just coming off your discussion with value-based care, we're seeing more and more that the care team that's multidisciplinary is going to be the direction we're moving to get to those clinical outcomes and cost-saving measures. So we're also training folks, we're doing leadership development, and really that's how we're going to get there. So these 4 areas we're really focusing on. Now the Clinical Affairs Division does this through our work as teams. So we basically work in 8 teams. We have 3 teams that really support the division on operations, communications, and our informatics team. We also have disease-specific areas like infectious disease and public health integration. We have our Million Hearts team. Cheryl will talk about the Quality Center, as well as we have senior fellows that we just hired this last year, who have 3 of them, I think total have almost 100 years of experience in health centers. And so they are helping to augment our work on the front lines. So really our goal with these 8 teams and our resources are to really build up the health center story, to support you all in the field at the PCA's, networks, and health center level, and then to really be able to tell that story to our state legislatures in Congress and other funders. So we'll be open for questions shortly. I will turn it over to Cheryl so that she can share with you some slides. So let me just turn back over to Cheryl and I'll stop the share. Cheryl?
I'm bringing up my slide here. Hold on one. Okay. I think we can see that. Can you see my slides okay?
Yep.
All right. So again, thank you. And I'm so happy to be here. My name is Cheryl Modica. I'm director of the Quality Center here at NAC. And I've had the pleasure over the last nearly 30 years, actually, of working in a variety of capacities with NAC, many of those years on projects and in a consultant basis. Have been in this role for about nearly 7 years. But my earlier years, I had the pleasure of working with primary care associations and health centers, and probably have visited close to, it was estimated at one point, probably 150 to 200 health centers, and worked with directly, and then probably visited close to 100. So have been in many, and that's been one of the most exciting pieces of the work that I've done over the years. So just to share a little bit then about bringing the work to the Quality Center, you can see on the slide that really we are all about collaboration, quality, driving change, partnerships. You will hear from the Quality Center, and hopefully do hear from the Quality Center already in some of our communications. But really the work that we do is intended to leverage and build on the great work that your organizations do. So we see ourselves at the national level, but our success is really driven by the extent to which we can partner, collaborate, and lift up your work and create models and work at the national level that you in turn can carry forth at your state or regional level. So that's what we get excited about doing. And so with that, I'll share the next slide. There we go. And so what this shares is our Elevate Learning Forum, National Learning Forum. Again, some of you may already be receiving communications. If you're not, as soon as I stop talking, I'll drop the link in the chat box and you can add yourselves. But nearly every PCA network nationally has at least one member participating. So again, your organizations may be receiving communication, but we certainly want to be sure that you yourself can get them if you choose to. But it's very exciting in that we're about 620 health centers, I believe, right now, who are participating in the Elevate Learning Forum. You can see again, 70 plus PCAs and NTAPs, et cetera. And so really what this learning forum is about is supporting health center systems change as health centers are moving on this journey towards value-based care. And so really what this last slide that I'll share with you today is about is it shares on the left side something we call the value transformation framework. So it's a conceptual model that is really meant to be an organizing framework for health centers and the PCAs and networks that work with health centers to try to take this really complex and really multifaceted work of systems change and transformation and value-based care, work towards value-based care, and to try to organize that and create a process and a system and a curriculum. And so that's what you see on the left-hand side of the screen is both the conceptual model itself, and then a little bit about our journey. And so that sort of line down the page talks about content that we're moving through during the 2020 year. Very excitingly, we're in the facet right now of building what we're calling, we might change the name. In fact, we might even have a contest or something fun to name it. But right now we're calling it Elevate You. But that by the time we get into 2023, it'll be more of this kind of university or self-directed learning with micro learning, so sort of 10-minute content pieces that folks can get some really evidence-based and good content quickly with tools and action guides and links to different content. And as you can see on the screen, all of this is driving us towards the right-hand side of the screen is really our goal, the quintuple aim. And that's how we define value. When we're talking about our journey towards value-based care, value-based payment, in terms of looking at what are we trying to achieve, and you can see what those 5 goals are on the right-hand side of the screen. So I think we actually are right on time for our allotted time. So I'll pause. In fact, I think we might have 2 or 3 minutes for questions, but I'll leave that up to Andy and Jen to indicate that. And again, I'll also drop in the chat feature the link so that if you would like to get more information or be connected to Elevate and you aren't already, we'll be happy to have share information.
Cheryl, thank you. And I'm not sure if it was just me, but I couldn't see the third slide. Not sure if that was for everyone else or just for me, but I could see your first two. Great, I see it now. Yes, now I see it. It was on the second slide also.
My apologies, my apologies. Okay. So feel free. So that is the slide that's representing the VTF on the left. Again, the curriculum kind of down the middle. That's our curriculum currently in 2022. And then the right-hand side of the screen are the quintuple goals. I will say, and we actually have a promotional piece that's going to go out in the next week. We'll have multiple sort of hits of it. So we'll be sending communication, but there'll also be some social media blasts. But there are the opportunity for PCAs and networks as part of Elevate to gift some scholarships to IHI to your member health centers. So again, stay on the lookout for that, but we're very excited by that opportunity where you may know some folks in the field, nurses, doctors, clinicians, QI folks who could benefit or desire to have some professional development in the space of quality improvement. And so we have scholarships to IHI's Open School, the Institute for Healthcare Improvement's Open School curriculum. So we're very excited by that, and we really want to place those scholarships in your hands and allow you to gift it to up to 1 or 2 folks in your state. So be on the lookout for that. I'll turn it back to you, Andy.
Great. Thanks again, Cheryl, and thanks again, Ron, for sharing that information. Are there any specific questions while we have both Dr. Yee and Cheryl on this call? It's your best time to ask right now. Feel free to put it in the chat or raise your hand if you like, especially when it came to what Cheryl was speaking about, the Elevate platform and getting on that list and some of the work that she's been doing with her team. There's a lot of great work going on in Cheryl's team right now.
And I am pulling up, as I promised, I'm going to pull up that link to put the correct one in, but we'll do that in just a moment, but happy to answer any questions.
Yeah, and I want to thank many of you that have contributed to a lot of the work we do in the Clinical Affairs Division. Many of you on this call are involved in our projects right now and in the past have contributed greatly. And this goes towards the evidence base, both on the clinical side, but also builds our story. As I mentioned, we want to give things to you all to use on the legislative level back in the state, but also congressionally. And we feed all of this to our policy folks so that they have a story to tell and some data behind it. So I want to thank you all again for all you do and your contributions, specifically on projects, but overall. So.
Great. I'm not seeing any questions come. Cheryl, just drop the link in the chat there. Thank you, Cheryl. Okay, well, if there aren't any specific questions, we'll thank Dr. Yee and Cheryl for joining, and you're most welcome to stick on. If not, we'll switch to the next meet and greet section. And up next is our Public Health Priorities Division. Ben Money is actually running late from another meeting that's still concluding right now, so we'll give him a couple of minutes to join in and introduce his division. But we also are very pleased to have Sarah Halpin, a program specialist, social drivers of health from the division, also on the call, has been doing some great work in the Prepare project, which she's got some information to share on today's call as well. So I'll hand over to Sarah. Sarah, thanks for joining us.
Awesome. Thank you so much, Andy. Let me share my screen real quick. All right. Can you all see that okay?
Yes.
All right, I'm seeing thumbs up. Great. Awesome. Hi, everyone. Great to meet you all virtually. I'm Sarah Halpin, the program specialist for social drivers of health, as Andy mentioned, as part of our public health priorities division. I'm joined on the SUH team by Nalani Tarrant, Yuriko De La Cruz, and Chloe Destinoble, who we all oversee NAC's work as it relates to Prepare, among other SUH-related projects. So for those of you who may be unfamiliar with Prepare, Prepare is the protocol for responding to and assessing patients' assets, risks, and experiences, which was created in 2015 in partnership between NAC, APCHO, and OPCA. And so Prepare has become a nationally standardized patient risk assessment tool designed to engage patients in assessing and addressing social drivers of health. There are 16 core measures as part of the tool, and 9 of those measures are also captured by the UDS. And by collecting the core data set, Prepare allows a health center or community-based organization to better understand how to best serve their patient population. Prepare includes several optional measures as well that look at incarceration history, domestic violence, safety, and refugee status. And while there are other SDOH screening tools, Prepare is the standardized screening tool of choice among health centers. Because it's actionable, it allows the care team to take action on patients' social needs. And this tool is flexible and can fit into any care setting or workflow depending on a health center's needs. It's standardized and widely used. So Prepare measures are linked with standardized codes like ICD-10, LINC, and SNOMED, and the tool is available in multiple EHRs as well. It's evidence-based and stakeholder-driven. So it was built, vetted, and tested with health centers and healthcare organizations across the US. It was designed to accelerate systemic change. So Prepare data can be used to show patient complexity through the development of risk stratification formulas, and it ensures the ability to better target complex patients in need of enabling services such as referrals and case management. And last, but definitely the most important why of Prepare is that it's patient-centered. So Prepare is really meant to facilitate conversations and build relationships with patients. And it's translated into 26 languages to help health centers connect with patients in a culturally and linguistically appropriate way. And this past year, we are very excited to announce that we launched a new website, www.prepare.org, which I'll drop the link in the chat as well. And that houses our materials and resources as they relate to Prepare and SDOH in general as well. And so if you're interested in learning more or would even like to have a training on Prepare or SDOH screening in general, definitely please reach out to our team. You can email us at prepare@nac.org, and we're happy to assist you however we can. So if anyone has any questions on Prepare, happy to answer, but hopefully Ben will be able to join us soon to tell us more about the awesome work that he and Jessica are doing as it relates to environmental justice and environmental health and food insecurity.
Great, thanks so much, Sarah. Are there any questions on Prepare specifically while Sarah's on the call? It's a quiet group again today. Maybe we should reconsider the meet and greets right up front, so everyone's awake at 2 o'clock rather than 3:45 in the afternoon. Well, Eastern time anyway. Questions for Sarah going once, going twice? Go on. All right, well, thanks for dropping the link in the chat there, Sarah. Again, lots of great work going on with Sarah and her team on Prepare too. So I'm glad that she could join and share some information with us. And Ben's just joining in the meeting as well. So maybe I'll give him 10 seconds to connect to his audio. Ben, no pressure. You just joined in the meeting, and we just wrapped up with Sarah sharing the work that your team is doing on Prepare. And we also heard from Dr. Yee and Cheryl Modica on the Clinical Affairs Division and Elevate as well. So I know you're coming from another meeting, so if you need another 10 seconds to grab your breath and drink a sip of water, you're more than welcome to take that.
No, I'm fine, Andy. I appreciate
like
that.
To share.
Yeah, thank you, Sarah, for jumping in and giving an overview of the Prepare team. So within the Public Health Priorities Division, we actually have 2 teams, the Social Drivers of Health team, which leads the Prepare work, but then we also have a Public Health Priorities team. Jess Henshaw is the program manager there. And within our public health team, we have environmental health. That environmental health focus looks at all those factors that influence the health of patients from the community environment, as well as looking at the impacts to the patients served by community health centers as pertains to climate change. Those are Environmental health is one area that's under Section 330. It's one of the charges of community health center, the community health center statute. And environmental health is an area that is really foundational to a lot of the early health center programs, particularly given the fact that many of the patients served by health centers live in communities that are disproportionately impacted by environmental justice issues, toxic waste dumps, flooding, poor air quality, and all those impact the health of our patients. We've got a number of health centers across the country that are working directly in those spaces, and it's an emerging area within the Biden administration, HHS as a priority for HHS as well as for health centers. So that's the other area, the other team within my division. And then the thing that I'm also working on and working with Jen Nolte, as well as working with Cheryl Modica and the clinical team, is on value-based care and supporting health centers and making the transformation to value-based models of care within Medicaid, Medicare, and commercial plans.
Great,
and
thank
Ryan
you, Ben.
Smith is one of my key allies in that. Don't let me forget you, Ryan.
See, Elena has her hand up. Go ahead, please.
Thank you, Sarah and Ben, very much for coming today. I guess, Ben, I've got two questions. It would be interesting to hear a little bit more about the specific projects that you all are doing on the value-based arena. We just, Rhode Island is part of the effort that Joe in Missouri is leading. Mm-hmm. So I'm still trying to figure out where there's overlap and distinction.
Okay, so we actually are working very closely with PCA, Value-Based Care Collaborative. When I was PCA director in North Carolina, I was a part of that, helped kind of get the genesis of that group going. And in essence, one of the things that we know is that Medicaid is the largest payer for health centers, and it will be the tipping point for value-based care. So Medicaid happens at the state level. PCAs are the point of contact for the state Medicaid offices, and CMS gives some fairly broad discretion for state Medicaid offices to initiate value-based care within certain parameters. And so NAC is really focused on working with CMMI as they are starting to pivot towards Medicaid value-based care planning and really looking at primary care and the safety net in general. So, our focus is really around trying to create those broader guardrails that CMS will implement with state Medicaid offices, but then also supporting the PCAs as they interact with state Medicaid offices and managed care organizations to establish value-based contracts. And we're very much attuned to the Learning Action Network framework for value-based care transformation, that 4-step process, and really working with Cheryl Modica and the Clinical Affairs Division on aligning our trainings and our offerings along that continuum.
Thank you, and I'm curious, do you have a sense of where CMMI is on FQHCs? It feels like they're not that familiar with the model.
Yeah, that's the thing that we've been doing, is really trying to educate CMMI on who we are and really what some of the important considerations that they need to factor in as FQHCs begin the process of exploring alternative payment models within Medicaid. We really feel like the ability of health centers to work within those clinically integrated network models, ACO models, is going to be important. because of economies of scale and being able to share analytics and certain strategies around care coordination and perhaps even, virtual specialties and the like, but also being able to poolize and have some means of providing third-party administration, as well as looking at, aspects around clinical risk and joint contracting. So there's some real strong efficiencies with that approach. And we've, I think, been very successful thus far in sort of introducing that concept to CMMI and having them say a CIN and a health center can follow the same rules. We also are really pushing back on CMMI in terms of some of their concepts around risk, recognizing that an FQHC, by definition, takes on risk by assuming care for anyone that walks in the door, regardless of their ability to pay on a sliding scale, and setting up their sites in medically underserved health professional shortage areas. So we're right now working on a finalizing the position paper that really looks at all the considerations that need to be factored in, and we're marrying that up with CMMI's Health Equity Action Team framework for value-based care. And then utilizing things like the NASEM report to be able to provide additional external validation for our recommendations.
Thank you very much. That was very helpful.
Thank you.
Does anyone else have any questions for Ben while he's on? Not seeing any. So I think we'll thank Ben for jumping from one meeting to the next meeting and joining us this afternoon. Ben, we really appreciate it. Hopefully you get a break at some point this evening. And I think I'll hand over next to Ryan to help wrap up the session for the day.
All right, thanks, Andy. And thank you everyone for participating today. We thank our guests and our SMEs and our NAC colleagues as well. We'll be updating NODLPod with the presentations today and the links shared as well. I'll be sending an email out likely tomorrow with all of that as well. Our next session is on July 14th, and we're going to be discussing building a legacy of governance. And so we look forward to that session in a couple of weeks. In the meantime, should you need anything, have any questions, feel free to reach out anytime. So y'all have a good day. Thank you so much.
Thank you. Bye.
Thank you.